Yeah, so we have Usha Chakravarthy, retinal ophthalmologist from Queen's University, Belfast, who is going to start us off with a lecture from Drusen to vision loss. What is AMD? So thanks, Usha.
Thank you very much. This was a very broad and wide remit, and if I don't cover what you expected, please talk to Florian, who gave me guidance on what I should put in my talk. So all your fault, Florian. Great pleasure to be here. And thank you very much, Diane, for all your help and assistance. One point I would like to make, though, is I always think of the brain as an extension of the eye, not the eye as the extension of the brain. In fact, for those of you who don't know, the first development of any kind of neurological structure in any organism was the eye spot. So the brain developed from it. Righto. So I'm going to give you a sort of a potpourri or a bird's eye view of what is AMD, and so I'm going to talk about Drusen to vision loss. Here are some of my disclosures, none of which are relevant to what I'm going to cover today. So I'm going to give you a little bit in terms of the learning objectives. I'm going to cover some of the definitions of AMD as we understand it, and then talk about some of the late-stage manifestations. If you just had what we call AMD, that is Drusen in your eyes, we wouldn't be concerned, but unfortunately it leads to vision loss, and that's the reason why we are, I'm going to sort of think about the earliest manifestations and then how these changes lead to vision loss, and a little bit about treatment and future directions. So what is AMD? We define it as a constellation of degenerative features that are seen in the macula of the aging eye. And on your screen up there, you see a picture of a normal eye, and the macula is the central region of the fundus that you can observe when you look into the eye. And it's called a macular lutea because of the pigment that's there. Now, as we get older, just like you get arthritic pains and your muscles slow down, etc., aging changes begin to appear in the retina that we can observe, and these are known as drusen. Drusen are accumulations of debris, basically cellular debris of lipidic and proteinaceous constituents that when you look into the eye, you see as yellowish deposits. And because we were originally looking at just images on color, and also because we could look into the eye through an ophthalmoscope, we started to relate their size to the size of a vein at the optic disc, and that happened to be 125 microns approximately. And so you kind of related the figures that you see here, 63 microns, 125 microns. There's no magic number, but it just happened to be somewhat related to the size of a vein, and you could therefore say that you had very small drusen or medium-sized drusen or large drusen. Subsequently, over time, epidemiologists began to separate these into categories of aging changes, that is drusen smaller than 63 microns, very, very tiny, and then drusen that lay between 63 and 125, and the relevance of this will become clearer with the subsequent slides. And then we started to call them early AMD, intermediate AMD, and then a further expansion of the intermediate AMD categories with drusen that were larger than 125 microns. And are these important? Generally, they don't lead to any functional loss, but then we began to notice that eyes that had these drusen were the ones that developed this condition, which we call neovascular AMD, because it is associated with the development of blood vessels in the retina, abnormal blood vessels that leak and bleed, and also regions of where the cells of the outer retina, that's the photoreceptors, the RPE, and the chora capillaris, begin to dwindle away and leaving behind a moth-eaten appearance rather like that, which we call geographic atrophy. More recently, in order to sort of make the nomenclature a bit more consistent and so that people could talk from the same language, we developed the Beckman classification. So you can see here the Beckman classification, and in one of my last slides, I'll give you the reference to the paper. And this is just a purely clinical classification of AMD. And you have multiple stages, the early AMD being medium drusen that are smaller than 125 microns, and intermediate AMD that is larger than 125 microns, and late stages of the late AMD, which is neovascular or geographic atrophy. As we improved our imaging technology, certain things began to be apparent. So these drusen, which are the classical AMD-associated drusen that we clearly recognize, occur in the subretinal, sub-RPE space with the RPE draped over them. And then we also began to recognize that there were drusenoid accumulations that occur in the subretinal space, which on color imaging were originally called reticular pseudodrusen because they form ribbons. And subsequently, we realized that these were not actually in the sub-RP. They were not like sub-RP drusen, but rather accumulated in the subretinal space. And then we also recognize another form, fairly common drusen, which are known as these little minute drusen, which light up on fluorescein angiography, which are the my brain's gone. What are they called? These are the... Cuticular. Sorry? Cuticular drusen. Thank you very much, yes. And the relevance of the subretinal drusenoid deposits and the cuticular drusen are still being explored in terms of AMD. I'm going to concentrate on sub-RP drusen because that's a topic of choice. And as you can see here, that although patients may not recognize the visual function deficits that accompany it, there are deficits. So comparing early AMD with control eyes that have no drusen, you can see that there are already minor differences in function. And then comparing intermediate AMD with early AMD, these are the slightly larger drusen, you can see that there are clear differences in terms of contrast sensitivity, low luminance acuity, that is when you reduce the luminance of the charts that you're using to test function, and dark adapted microperimetry, where you stimulate the retina with very minute foci of light and obtain the retinal sensitivity at that point. We also did some work on looking at reticular pseudodrusen and function, and what we observed were two things. First of all, that the deficit that you get when you reduce the luminance is much greater in eyes that have the pseudodrusen, and also that dark adaptation is delayed. That is, the ability to move from bright into dark conditions and to be able to see quickly, just like you would go into a cinema or somewhere like that, is greatly reduced in these patients, but also that they're collinear and occur in the same eyes as the nodular classical drusen. This is work from the age-related eye diseases study, and as you can see here, progression does occur. So if you look at the eyes that had very small drusen or no drusen, and how do they increase in size? And the answer is, yes, they do. In about 10 years' time, approximately 10% will have these larger drusen greater than 125 microns. But then if you have medium drusen in one eye or medium drusen in both eyes, the rate of progression to these larger drusen also increases in frequency. And but as we then improved our imaging systems and got beyond these color images into the near-infrared and autofluorescence and using spectral domain OCT, we can see that these are not the same eyes, by the way. It's not longitudinal progression. I'm just showing you how the drusen severity changes. So this eye has got small drusen. Here we have much larger drusen, and here we have much larger drusen accompanied by pigmentary migration. So the RPE cells are migrating into the outer retina. And then here you can see a very typical case of geographic atrophy, where all of the outer retinal layers, that's the nuclear layer of the photoreceptors, the photoreceptor segments, inner and outer segments, the RPE layer, and the chorea capillaris has all vanished, allowing the spectral domain OCT signal to transmit right through like this sort of bright bands, indicating that the outer retina is lost, and this is now advanced geographic atrophy. The ARED simple scale, which was developed showing the 5-year rates of progression to advanced AMD, there's both geographic atrophy and neovascular AMD, is seen here. And the interesting thing about it is that if you have these little tiny drusen without any pigmentary changes, then the progression rates over a 5-year period are extremely small. But when you have large drusen in both eyes, and without any pigmentary changes, the progression is around 13% over a 5-year period. But the moment you start to see these pigmentary abnormalities in both eyes and large drusen in both eyes, the rate of progression is 50%. So 1 in every 2 of these eyes progress to one of the late stages. So what is this telling us? That sub-RP drusen are indeed an early manifestation of AMD. They gradually increase in size. Drusen lead to RPE and photoreceptor degeneration, and they're associated with subtle deficits in function, and that pseudodrusen often occur in conjunction with the sub-RP drusen, but their role in AMD is still being debated, and eyes with these pseudodrusen also, which exhibit dark adaptation and low luminance deficits, and they can be symptomatic. I think others are going to cover much more on the AMD pathobiology, but essentially the work that's come from Link Johnson and others has shown very nicely that for the photoreceptors overlying and flanking drusen exhibit signs of degeneration. Now I'm going to take you through the progression to atrophy. We did some work called the Early Markers Study, where we had a group of patients that we followed over a period of time from 3 study sites in Europe. And here is an example of actual progression. So this is a spectral domain OCT scan. Here's the near infrared showing that there's a lot of changes in the macula with drusen. And what you'll observe here is some minor disordered autofluorescence. This is blue light autofluorescence. And the autofluorescence signal arises from the RPE. Normally it should look nice and bright like this, but over time, this eye, you can see how the RPE is now beginning to vanish. The outer retinal layers have disappeared, and so the inner retinal layers are collapsing into this gap left behind, and subsequently there is loss of the complete loss of the outer retinal layers, and you see these dark patches beginning to appear. So it's multifocal geographic atrophy with these lesions coalescing over time. So it's just to show you the progressions through early abnormal autofluorescence and then into regions of geographic atrophy. Now, what about progression from intermediate to neovascularization type of AMD? So essentially, normally the RP is tightly opposed to Bruch's membrane, which is its basement membrane. And in some intermediate AMD eyes, where they have, when we used to do fluorescein and ICG angiography, we could see that that you could find these sort of bright plaques on ICG angiography, this indocyanine green angiography. So the ICG dye binds very tightly to plasma proteins, so it's retained within the choroidal vessels, which you see here. And in such eyes, when we got the chance to observe them on a spectral domain OCT, we could see that there was a shallow, irregular elevation of the RPE from Bruch's membrane. But you'll observe that there is no exudation in that region. So Phil Rosenfeld did some very nice work using OCT angiography, a non-invasive way of looking at blood flow, and he showed that these regions where there was separation of Bruch's membrane from the RPE contained blood vessels in which flow could be demonstrated. Subsequently, Robin Guymer's group in Australia looked at these sorts of eyes that had the shallow regular elevation of the RPE from Bruch's membrane, and documented that heterogeneous reflectivity within this space, the sort of disordered reflectivity in this sort of region, and the length greater than 1,000 microns and a height less than 100 microns on spectral domain OCT associated more strongly with the presence of blood vessels on an OCTA. We looked at 460 eyes, high-risk eyes, and we classified them into eyes that had no irregular elevation of the RP due to drusen, but without features of what we call the double layer sign. And then we also measured the length and the height of it, so that we could separate these categories out into those that exhibited the double layer sign and those that had the sire sign, which Robin Geimer's group described. And we plotted the progression to neovascularization. Because these patients were followed up at very regular intervals, we had excellent data on the time of development of neovascularization. So any high-risk eye that was the fellow eye of somebody that already had neovascularization, one eye, had a risk of progression even if they didn't have a large number of drusen. As you can see here, the blue line is just dropping off slowly, but eyes that had the irregular elevation did develop neovascularization faster. And if they look like a DLS, where they had this heterogeneous reflectivity in that sub-RP space, they progressed even faster. The dimensions didn't really make any difference because the rate of progression was very similar whether you measure the dimensions or not. So now we have a practical marker that we can look at on spectral domain OCT and say that you're at higher risk of progression if you exhibit the double layer sign. Now, what about progression to actual exudation? Here's an example of an eye, again taken from our longitudinal data sets. Here is a druse, and you see that some of the RP is beginning to migrate there. You see that the druse is beginning to collapse, and there's hypertransmission through this collapsing druse, and then suddenly there is fluid accumulating in this subretinal and it leaking into the neurosensory retina. And on fluorescein angiogram, you can see a leak that develops. So to summarize, the separation of the RPE from Bruch's membrane with heterogeneous reflectivity is a key step in the pathogenesis of neovascular AMD. This double layer sign is an indication that new vessels have breached Bruch's membrane and therefore could be a marker for more rapid progression to exudation. The measurements of length and height are not particularly valuable in a pragmatic sense, but may have relevance in other types of projects. And new vessel complexes arise adjacent to regressing drusen and invade the sub-RP and subretinal space, leak fluid and blood. And then now I'm going to talk about progression to vision loss. You've already seen the schematic slides, and you know that early AMD features worsen slowly. Here's an example of a case that's progressed steadily. This is a longitudinal follow-up, and at baseline, the patient is seeing 85 letters on a chart. That means pretty good vision, reading all the way down to the very tiny letters, even though there are some drusen. At 4 years, vision has dropped a little. You can see a great deal more of these drusen accumulating, but by 6 years, there's a clear patch of geographic atrophy and the visual acuity has dropped. This means the patient can now read halfway down the chart with that eye. Now, with neovascular AMD, of course, there's worsening of the early to intermediate AMD stages, but no effect on function until you get this kind of leakage. So here you see a particularly aggressive form of leakage into the retina with fluid accumulating. And of course, when this happens, there's immediate onset of distortion and reduction in vision. So in geographic atrophy, we looked at a very large number of cases in an electronic medical record system. You can see here that the median time to lose approximately 15 letters, that's a doubling of the visual angle, is around 3 years, but it happens more gradually. But with neovascular AMD, on the other hand, the same amount of loss occurs within 12 months. So it's a much more rapid form of vision loss. Now, how do we manage these conditions? This is a very quick gallop through for the next couple of minutes on management of clinical management of AMD as it stands at the moment in terms of therapies. Now, suppression of VEGF is the key to reducing leakage from the blood vessels and stop the expansion of the new vessels that are formed. And here was the sort of pivotal trials that established this, the Anchor and Marina trials, which was published in the New England Journal of Medicine in 2006. Patients received an anti-VEGF treatment known as Lucentis, ranibizumab, and for the first time, we actually observed overall improvements in visual acuity from their starting points, whereas previously most patients, whatever treatment we were using, including laser treatments, photodynamic therapy, etc., lost function. So this was an important mark in the terms of therapeutics of neovascular AMD. However, while we were delighted with the treatment initially, of course, where the proof of the pudding is in the eating, over time, a lot of patients continue to lose vision. And so here you can see that the type of neovascular AMD has an impact on how well they respond to treatment. So we've got something known as type 1 vessels. Now, all this recognition has come about through the use of multimodal imaging. So you can see here a case where we've got leakage on fluorescein angiography and ICG angiography. This is a spectral domain OCT scan showing the presence of the leak, which is seen as a pile of hyperreflective material accumulating in the region of the outer retina. And after treatment, and we know that these vessels are lying in the subretinal pigment epithelial space with fibrinous exudate coming into the subretinal space. On treatment, the fluid leakage is stopped, this stuff gets resorbed, and we are left with something that looks more like normal, but it is, and you preserve function and you also improve function a bit. Now, here is another example, which is a type 2 membrane, and here the blood vessels are ramifying. They breach the RP barrier and come to line the subretinal space. There is subretinal fluid, there's intraretinal fluid, and after treatment, although the fluid is gone, we are left with a patch of fibrosis, and over time, although this fibrotic material will thin and remodel, we still have a lot of distortion and loss of the outer retina and atrophy. The third type of neovascularization that we recognize is known as a retinal angiomatous proliferation, or a RAP. This type of lesion tends to occur much more in eyes that exhibits subretinal drusenoid deposits, and the neovascularization comes from blood vessels lying within the retina, so from the deep retinal circulation, not the choroidal circulation. And these vessels leak fluid into the retina. The unfortunate thing about the RAP lesions, although they respond beautifully to anti-VEGF treatments, which are all put into the vitreous, so they deal with the exudation very rapidly, the neurosensory retina has already undergone a degree of atrophy, so we've lost neurosensory retina, and as a consequence, visual function can be diminished and does not really recover to normal. And the final type of neovascular complexes that we recognize are known as polypoidal choroidopathy, where the new vessels arise in this choroid, but they contain polypoidal extensions, much commoner in the Asian countries, but also seen in Caucasian neovascular AMD. And this type of neovascularization responds reasonably well to anti-VEGF treatments, but again, fibrosis and scarring and loss of the outer retinal layer is quite common. So one of the observations that has been made through important immunological discoveries is that dysregulated complement inhibition, which is modulated by genetic risk, has suggested complement modifiers as therapeutic targets. And the two main therapeutic targets that people have concentrated on in the past decade is C3 and C5. And we know that the alternative pathway in fact, all the pathways go through these steps, leading to the development of membrane attack complexes and lysis and cytotoxicity. And the drusen contain a lot of complement proteins. So as a consequence, the discovery of genetic variability in these as risk factors for AMD was a big eureka point. Unfortunately, although various trials have been done, we've got Oakes and Darby, which targeted C3, and we've got the Gather trials that targeted C5, reducing the growth of geographic atrophy in patients that had geographic atrophy. There was no commensurate reduction in the visual loss. So as you can see here, the visual acuities of patients who were treated and the patients who were not treated just overlapped over time. So again, a summary of this part of the talk: anti-VEGF biologicals have varying durability. You may need a lot of retreatment, and this need varies by the type of neovascular AMD and the severity of exudation at detection. And since their introduction, we know that the numbers of severely visually impaired have dropped extensively in the EU. There is no universally approved treatment for geographic atrophy. Complement inhibitors slow the growth of GA, but without demonstrable benefit on function. So here are my take-home messages. AMD is a bilateral degenerative macular disorder. It commences as drusen, sometimes with mild visual dysfunction. The late-stage manifestations are wet AMD, neovascular, and GA. Exudation is controlled with anti-VEGF agents with visual benefit, and atrophy expansion can be reduced by complement inhibition. There are quite a lot of unanswered questions, and here are some important ones in my view. There are many, many more. So the question is, are pseudodrusen AMD or just an associated feature of aging? In which cell or cellular layer does the process of degeneration begin? The photoreceptor, the RPE, or the choroid capillaris? Or are they lead to different phenotypic forms of AMD? Is atrophy the default pathway? And where do neovascularization and geographic atrophy diverge? And here are a couple of references for further reading. I would recommend the Beckman classification, because this is a very commonly used one, and also a narrative review that Monica Fleckenstein and I and Schmidt-Valkenburg wrote recently. I'd just like to thank a lot of the people who contributed. These were the graders in our imaging center and some of my key collaborators, and thank you for your attention.
Excellent, thank you. So that's sort of...
It's a whistle-stop tour, wasn't it?
So it was really, really nice. I have lots of questions, but I think we should seek some young investigators who just realized that their research project has to be adjusted to whatever question.
Hi, Usha, great talk. I was wondering, what do you think is the actual difference between the pseudodrusen and the drusen in terms of, for example, when you're trying subthreshold laser therapy to try to see if you can rejuvenate RPE cells? What do you think is the difference between those type of drusen that in pseudodrusen it's less likely to be effective?
So the difficulty obviously is that as you age, you get pseudodrusen, you get the deposits forming. You also get nodular drusen. There are very, very few eyes where you get only pseudodrusen. So if we separate them out and you look at them, then they all the same risk factors appear for both, okay? So we can't really dissect out the different contributions of these types of drusen. But we do know that when you have a lot of pseudodrusen, you're more likely to have a RAP lesion than otherwise. So what this is suggesting to me is that it's creating a diffusion barrier, possibly leading to more photoreceptor hypoxia, and therefore leading to therefore leading to outer retinal ischemia, hypoxia, and blood vessels developing from the deep inner retinal layers forming. Does that answer your question?
Thank you for your lovely talk. I never knew that there was actually 4 types of wet AMD, but I was wondering, you said that they respond differently to VEGF treatment. Is there one that works better? Like, what type worked better with VEGF?
Sorry, I'm finding it very hard to...
She was asking the different neovascularization types respond differently to the anti-VEGF treatments, and
okay.
which ones just really...
So, yes, anti-VEGF agents are put into the vitreous, and they control exudation. It doesn't matter whether the exudation is in intraretinal or subretinal, the agents clear it up, okay? They restore competence to the blood vessels that are lying in the subretinal space. They're less effective on the blood vessels that lie in the sub-RPE space. So you will find that pigment epithelial detachments, which are an indication of fluid leakage in the sub-RPE space, reduce, but they don't go away completely.
I think the second part of her question was which one, in your professional opinion, works better. But I mean, that's a complicated question.
What type of anti-VEGF agent is better? Right. So we have. I couldn't go into all that detail in this talk. So there's a lot of anti-VEGF agents. We started off with ranibizumab, and then we went on to Eylea, which is aflibercept, and then we went on to brolucizumab, and then now we have faricimab, which is a bispecific antibody. So all these agents have not really made a big difference to the final visual function. But what they have done is they've given us a little bit more durability, so you can control the exudation for longer periods of time. At the end of the day, what we need is an additional neuroprotectant and something that prevents fibrosis. If we could do that, then we will have a much better drug.
And we also understand that there are non-exudative neovascularizations that are actually quite good to have, right?
Come closer.
If you have non-exudative neovascularizations, that's actually
right,
not
yes.
so...
If there's non-exudative neovascularization, you don't touch it. Because those blood vessels are lying external to the retinal pigment epithelium. In all likelihood, they are nourishing that RPE, so why intervene?
I had a quick question about the double layer sign and how clinicians are thinking about using that, and what kind of imaging, or I guess what time point even clinicians are starting to think about using things like OCTA to try to detect that sign, and what that looks like for patients.
So, in the past, we had fluorescein angiography and ICG angiography. These are dyes that are injected into the peripheral circulation, and we take images. And they have certain mild side effects, like you feel a bit nauseous when you're getting the treatment, when you're getting the imaging done. So it's not the ideal form of imaging, but on the other hand, it gives you information on leakage, fluid leakage, and you know which compartment it's in because you combine it with spectral domain OCT. Now with OCT angiography, it's a very different way of looking at the outer retina. There are many. So with OCT angiography, we can observe. We can do three-dimensional representations of where the blood vessels lie, and because it's non-invasive, you can take multiple images all the time. Every time a patient comes, you can do your OCT angiogram. So you can plot the growth of blood vessels, you can see them involute. But there are problems. It doesn't show you leakage. And also, if you have very slow flow, you won't see it. If you have very fast flow, you don't see the vessels either. So it also doesn't tell you how active those neovascular complexes are. So there's certainly, most of us in the clinical arena have moved completely to spectral domain OCT as our first line of investigation when we see a patient where we suspect choroidal neovascularization or RAP lesions, and also we would use OCT angiography. The difficulty in the UK, because we are a national health service, the storage of these images becomes a big problem, and retrieval to examine them, and therefore we get pushback from our IT department saying, no more, clean up all your image sets.
Thank you for this talk. It's here, right in the back. I just wanted to circle back to the vascularization and the different types of vascularization, and I wanted to ask you, are these types specific for the individual, or can the same individual actually exhibit different types?
Absolutely, excellent question. There is a degree of symmetricity. So yes, if you get a type 1 lesion in one eye, you're much more likely to have a type 1 lesion in the fellow eye as well. But the type 1s and type 2s are quite often mixed, because it's all choroidal neovascularization. And these neovascular complexes, you may just have a more advanced disease or a bit more or more severe RPE disease, leading them to become type 2s quite easily. The type 3s are quite classic in the sense that if you have a RAP lesion in one eye, you're much, much more likely to have a RAP in the fellow eye. And then there is the polypoidal choroidopathy, the PCVs, so much more commoner in Asian countries. But they all share this similar risk factors, systemic risk factors such as things like smoking and age are common regardless. And then the genetic risk factors are also much the same. So we kind of struggle to see whether there are very specific risk factors that would determine whether you get one or the other. And so far, I don't believe that any group has been really successful, even though there have been some publications in the literature indicating that one particular genotype might be more associated with a particular form of neovascular AMD. There's been no consistency of publications, put it that way.
Joe Hollyfield, thank you for that very nice talk. You didn't mention the risk factor, genetic risk factors, until right at the very end, and I realize that there's talks that will follow that will focus on some of these, but I wondered how helpful is it to know the genetics of AMD patients in predicting the progression of the disorder, or if there are certain risk factors associated with one or the other forms in the classification scheme that you've described?
I wish I could say I knew the answer to that. The answer is I don't know the answer to that. If you take the view that we've learned so much from cancer treatments, where knowing the genotype is very helpful in tailoring therapeutics, in neovascular AMD, we don't have that information. We've never really systematically looked over time to assess if we do have the opportunity. We've never exploited these opportunities, okay? We have them, but we didn't. And I don't see at this moment in time a reason for performing genetic risk studies in terms of routine care, but in terms of understanding whether there are better ways of managing patients with specific genotypes, the answer is yes, these studies should be done. But I don't see a reason from the literature that I'm aware of that would sort of direct me towards genotyping my patients before I treat them.
Usha, I was wondering if you could speculate or talk about difference between soft and hard drusen, and the disease association and perhaps speculate on the origin.
Sorry, I missed what you said.
Soft versus hard drusen.
Oh, soft versus hard. Right, okay. So the Ehret's work suggests that the hard drusen eventually becomes soft drusen. So it's just an earlier sort of stage of drusen development. We call them hard because they were very tiny. This was sort of the nomenclature rather than a real sort of understanding of what the pathogenesis of these different drusen types actually mean. So is that, Tiernan, would you agree? Yes, he's saying yes.
But not all hard drusen will become soft drusen. You need a lot of hard drusen.
No, that's true. But then, so you will have, if you have, some hard drusen may disappear, but others, there's so much remodeling going on in the outer retina of all this debris that collects there. I wish we could have had, sequential histology, but we just don't.
Yeah.
We only have snapshot histology at one moment in time, so we cannot draw these inferences, not unless you start to do some very smart organoids or something like that, and make those organoids, create little mini drusen and watch them grow, maybe feed them lipids.
So if you had a grant proposal, and in the grant proposal they show you hard drusen with their protein of interest in it, and say it's a proof that it's implicated in AMD, is that good, or is it not enough because you would really want to have it in
I would disagree. I would say that if you have little tiny hard drusen, I don't think you could call them AMD at that point in time.
So when you look at your histology, you need at least 125 micrometers, which is half the thickness of the retina on your picture, basically.
Half the size of a retinal vessel at the disc.
Ah.
That was the only marker we had at the time. Of course, now there's been work that's been done which shows that we were not that far off. It was in terms of estimating drusen diameters, we're not that far off.
Ah.
It was a reasonably pragmatic marker.
So here too, there first. And please stand up when you ask the question so that we can nice pictures.
Great talk. It's here.
Oh, thank you. Yeah.
Slightly changing gears, like in some inherited retinal diseases, you have CNVMs. Do you have any guideline from your expertise or anything where if you still will think that if it is non-exudative, then you don't treat at that time? Or do you have any guidelines?
So when it's in the non-exudative state, you don't treat. I mean, the risk of you're sticking a needle in the eye and delivering a drug which will completely neutralize all VEGF. VEGF is a maintenance factor for the neurosensory retina. It's important for blood vessel health, maintenance of the endothelium. So why do you want to sort of intervene at that stage? But what you do want to do is follow these patients up carefully, because they can progress to neovascularization, exudative neovascularization. And when you detect that, the earlier you treat, the better the outcome.
Hi, thank you. So going back to the different types of neovascularization, if we're interested in recapitulating this in mice and trying to understand how different inhibitors might work better, would you say that there's a certain type of neovascularization that would be most important to focus on when testing drugs, or is it important to recapitulate all the different kinds of neovascularization in mice models?
So in the animal models, it's almost impossible to recapitulate what you see in the human eye. The animal models of neovascularization generally have been generated through focal injury. So it's an acute inflammatory insult that you're delivering in a focal way to a region of perfectly reasonably healthy retina in a young animal. So it just does not recapitulate it. What you could do is when you have you can tell that the drugs are effective because it stops the leak, okay? But in the animal model also, the healing processes are very rapid and does not resemble anything like the changes that you observe in the aged human eye.
But there are genetic models where you have reps like LDL, some knockouts that make neovascularizations
sorry,
from the retina.
Florian, you're very muffled from
sorry.
that.
There are other models than the laser model, like the VLDL receptor knockout, so they grow from the retina. Is that better, or do you think that's differently bad for other reasons?
Yeah, yes, there are opportunities to develop better animal models. The difficulty, of course, is that the changes that occur in the human eye, sort of, reducing choroidal blood flow, the extensive changes that occur in the retinal pigment epithelium, to recapitulate all those effects is going to be impossible.
Yeah, Pat Becerra from NEI. You spoke about subretinal, sub-RPE, cuticular, small, large, soft, hard. So let's put them all together. Do you know, or could you comment about markers, specific markers for the different types that you've mentioned?
Sorry, I missed that last sentence. You were too fast.
The markers, if there are markers for specific type of Drusen.
I think that question would be best addressed to somebody like Christine Curcio, who's looked at the histology of all these different distributions of drusenoid material. Unfortunately, I can't give you any direction on that.
Thank you so much.